Welcome to Learning Plan 2, where we will be talking about healthcare ethics. Why do we talk about ethics? Ethics will drive much of our profession and how we handle situations. There will be times when we are put in a position where we need to do something that personally we wouldn't choose, but we have to because it's the patient's choice. That doesn't mean we have to like the choice, but we have to work with it. And understanding our personal choices, our personal ethics, will make it easier in the long run to handle these ethical dilemmas. And what is an ethical dilemma? It's a situation where there are no good choices, where there are no hard and fast rules to follow, no specific laws or standards that you have to follow. These are the gray zones of nursing. And there are a lot of gray zones. And this is where students start to have major problems. Many students are trained and feel that everything is exactly in a straight line, no deviation. And that's not real life. So we're going to talk about ethical dilemmas and how to handle them in this lecture. And I won't presume to tell you your ethics. And no matter what your ethical choice is, it's right for you. Not necessarily me or the person sitting next to you. But we all have our own set of ethics, our own code of conduct. We just have to make sure that our personal code of conduct is relatively in line with the agency we work for, our employer, the people we work with. So that'll just make things easier for everyone. So how do we handle ethical decision making? These are some key terms that we need to understand. The two key terms here are deontological and teleological. Deontological, there are guidelines for everything. Based on a duty or moral, are always held up. The slide has always feed patients, and that all life is worthy of respect. Always. These are carved in stone for these people. If you are deontological, this is your bedrock. You have a deontological view that there are specific things that you can do and you can't do, and you don't cross that line. Now, I'm not talking about laws. That's Learning Plan 3. I'm talking about ethical line. You won't cross that ethical line. So that's deontological. A situation will always be handled. Terry Schiavo in Florida, when she was brain dead and feeding tube, people wanted to keep feeding her. They had a deontological belief that her life was special and sacred, and you cannot stop feeding her. That's a deontological view. Now, a teleological view is the opposite. That sometimes the end justifies the means, or that you look at things from a different viewpoint, that an outcome might end, you will end up with a good outcome based on your actions. Going to Terry Schiavo, people who were teleological would have believed that her life was not a life worth living, and therefore withdrawing food was the correct response for this situation, for this person. So teleological looks at the situation, looks at the big picture, and makes a decision for that. Situational sounds like it's teleological, but it really isn't. Situational is much more wishy-washy. A person who is teleological with the Terry Schiavo case, they're going to say, this patient is brain dead. This patient has no quality of life. This patient has no interaction with life. This patient is essentially no longer living. They're alive but not living. Therefore, we're going to withdraw food from her, and that's an appropriate action. In a person who's teleological, they're going to say that for everyone who's brain dead. A person who has a more of a situational viewpoint might say that for Terry Schiavo, but if it's their child, they're going to say, no, in this situation, it's all different. No, it really isn't. They're applying different sets of ethical decision-making to that situation. So deontological, very narrow viewpoint. It is what it is, and no deviation. Teleological looks at everything and looks for the best possible outcome, even though it may take actions that some may not agree with. And situational, they're going to do what they want to do based on that person, that day, that feeling. They may be deontological choices some days. They may be teleological choices. Some other key terms for ethical decision-making: autonomy. Autonomy is important. Autonomy is being self-directed. I'm in charge of me. Me. I'm not in charge of you. But when does that start? 18? When you're an adult? 16? 12? 2? That's a challenge. When does autonomy start? When a person can start to voice their opinions? Well, maybe. I mean, if a 5-year-old says, I'm sick, I need medicine, I can't imagine that saying, you're going to give him medicine, right? Because you're going to honor their autonomy. Not really, but go with me on this example. On the other hand, if the 5-year-old says, I want that beer, okay, you're not going to honor their autonomy. So when does autonomy begin? It's going to vary. Beneficence and non-maleficence. Flip sides of the same thing. Beneficence, do good. If you are beneficent, you are always doing good. That's your guiding principle. I'm going to do good today. Non-maleficence is a little bit different. I'm not going to do bad. I'm not going to do harm. One is focus on doing good. One is I'm not going to do bad today. And then justice, treating everyone equally. Equal freedom from being harmed. Just if you're acting in justice, you're treating everyone the same. Okay? So that's justice. Now, what are your values? Some questions to think about. When does life begin? We all may have a different answer for that. If I can't make my own decisions, who should decide for me? And on what basis? That's important. Remember, we talked about advanced directives in the last lecture. We're going to talk about advanced directives a lot in this lecture. What activities do you value? What medical treatments do more harm than good? Is healthcare a right or a privilege? That is a major healthcare ethical dilemma right now in this country. Is healthcare a right up to all citizens, or is it a privilege? And I would imagine in class we're going to have some discussion about this, because that's an important question. And I don't expect everyone to agree. Things that can influence ethical decision-making. A big thing is demographics. A person who's 80 may have a very different view of life than a person who's 20. Technology. A person who has access to high technology may make different decisions than a person without that access. Legal and regulatory issues. Current research, evidence, mainstream culture. What does the local culture feel? Is there a healthcare culture of one unit, of a unified form? And are there available resources? Are there money, personnel, equipment? Those all change a person's decision making, or can be a factor in a person's decision making. So end of life and ethics. At the turn of the century, most people died at home. But for the past 50 years or more, most people die in institutional settings, hospitals or nursing homes. And chronic illness is the greatest cause of death. What happened was major changes happened in the second half of the 20th century. Cardiopulmonary bypass was started in 1953. Well, that enhanced people with cardiac disease, enhanced their lifespan. Mechanical ventilation in the 1940s and 50s became the treatment of choice for polio victims who could not breathe. Hemodialysis began in 1960. Defibrillation and cardiac pacing were developed in the late 50s, early 60s. CPR was first reported in 1960, allowing clinicians to intervene. So, all those changes, think about that. Cardiopulmonary bypass, mechanical ventilation, hemodialysis, defibrillation, those all prolong chronic illnesses. They don't change or reverse or cure a chronic illness. Well, cardiopulmonary bypass may be curative, but usually it's just a pushing back the clock a little bit. But all these treatments serve to prolong a person's life, which brings about the chronic illness and the fact that most people die from chronic illnesses. Current research findings: only 13% of acute care patients get CPR at the time of death. What? Well, they're in the hospital. Shouldn't they get CPR? Most people have advanced directives or are no code. So that's why only such a small number of people get CPR in the hospital. So most people, more and more people are thinking in advance and planning for these situations. When I had my surgery on my knees, I filled out advanced directives naming my wife as my power of attorney if need be, and being very specific on what I wanted and what I didn't want. At 52, I made one set of decisions. When I'm 72, I'll probably make some different decisions on what I want done and what I don't want done. That's not changing ethics. It's changing demographics, changing life perspectives. But that's the end of learning part 1 of this learning plan.